Welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Very excited to be sitting here with the one and only Abe Sutton. Mr. Abe Sutton is the director of CMMI, the Center for Medicare and Medicaid Innovation Center, which didn't say that correctly, but that's what it is. And we're here in person. I've heard so much about you. Thank you so much for taking the time.
Thank you so much for the invitation to be on. It's great to be with you.
It's an absolute pleasure. So you are coming off of Rubicon, which is a very big company. It's an exciting company. It's venture. It's cool. And then you left that to run government and sit all day in an office that we couldn't even, they don't have very fancy offices in the government, which is a good thing.
You got a view of the Capitol.
We do have a view of the Capitol. For those that can't see, there's a beautiful view of the Capitol. But why? Why'd you do that?
It was really the furniture.
It was the furniture that got you.
The government in healthcare really plays a unique role. You have the opportunity to reshape the entire system. It's slow and incremental, like Burkean conservatism definitely shapes the administrative procedure and how we work as a government. But you have the opportunity to drive change. And like people talk about, the pace of government is slow. For the scale at which you're operating with $1.7 trillion across Medicare and Medicaid, it's warp speed. And you could push forward change that helps people get access to better quality care and have healthier lives.
Yeah. To kind of double click on that and zoom out a little bit, your journey is a little bit more interesting because you were at government. You weren't at CMMI in particular, but you were working with the White House in some capacity, which we could talk about. And then you went private to the private sector and you're working in venture, but still involved. And then you came back. And so I think it's worth even diving into further. Like, you obviously felt that you can actually accomplish more sitting in the seat where it feels like I'm curious how it feels to you, if it feels like you're moving fast or slow. But anything that's going to be at the governmental level, if you're not literally never getting anything done, then you're moving very quickly. You felt you can make more of a difference here.
Yeah,
Why?
I think it's the scale you operate and the fact that you set up the structure that people will respond to. You could sit back in a government role and just take meetings and see people all day. And I guess that's fun for some people. There's intellectual curiosity still because you're learning. But what I enjoy doing is thinking through, all right, well, how can this change? And what would the incentive be if it changed? How would people respond? How would this change how care is delivered? How would it help people live healthier lives? And the opportunity to look across different parts of the healthcare system and say, all right, let's tweak how payment flows in this small part of Medicare, and suddenly billions of dollars are flowing differently. So innovators are stepping up to act in a different manner. Systems respond in a different way, and new players come into play. That's a good thing. And the ability to say, all right, I see this as a problem. I want to make it better. I want to make a difference for people. Government's where you could drive that change in healthcare. You could respond to that incentive structure on the private side. You could build exciting things. You can innovate. But the structure within which people innovate is set by the payer. And the payer in healthcare is the government.
Predominantly. So what were you doing in the first Trump administration?
Similar focuses on Medicare payment and on ways to help people live healthier lives. I started out working at the National Economic Council. And so I focused on healthcare policy. There was a really forward-thinking leader named Brian Blais who ran the health portfolio there. And I had the privilege of working under him to help focus in on Medicare, on Medicaid, and on payment models. And so I got the opportunity to work on nephrology policy in particular as an area, on a number of the payment models that the Innovation Center drives. I had a hand in helping shape and got the opportunity to learn a lot, work on some drug pricing things. And then I became an advisor to Secretary ASR, and then I left the administration. So I had the opportunity to work on some cool policy areas and shape some of the early things for the first 2.5 years.
Cool. So it was like kind of early education on the way things worked and how to get things done. And then you went to the private sector, but you were still working kind of with healthcare, right?
So I started a job at a private equity fund called Rubicon Founders. And at Rubicon, I mostly worked not on a classic PE investment book, but more on starting new companies that would set up new ways to care for people. So how could we deliver care in a better way to patients with kidney disease or patients who are cared for by primary care physicians? How can we change it so you could spend time with patients in a way that helps them get better quality of care and not be driven off of this fee schedule that someone in Washington wrote? that was the mission. And I started 2 companies with co-founders with Rubicon backing to do that. And then I spent time thinking through other ideas for companies, most of whom we did not launch. And so there were some ideas that I don't know what's happened because I stepped away from, but I spent a lot of time thinking through things. Then we saw, it doesn't make sense to proceed with. And that's what a lot of it is when you're thinking through new innovative companies.
Mm-hmm. Now, coming into this role, so that kind of gives a lot of context to this, but coming into this role, it seems like you're moving very quickly. And so you came in, 6 months ago, couple weeks ago, maybe a month ago or so, you put out a letter with kind of a strategy letter from you, talking about what you want to accomplish. A lot of really good things in there. A lot of emphasis on value-based care, a very big emphasis on patient empowerment, data interoperability, and a lot of really important things. And then it seems like you guys are just it seems like you're moving along very quickly. And I've also had the opportunity to interact quite a bit with your team, and every single person just seems to have this speed energy where people are on top of it, they're getting things done. How are you accomplishing that, and specifically within the confines of the chains of government regulatory red tape?
I think I have the advantage of leading a unique organization. The Innovation Center draws people in who want to drive change. If you think about a normal government role where you're in a regulatory position, it's regulation, which interprets statute, or it's guidance that interprets regulations. It's working within the confines of existing structures to try and say what they mean. And you tweak on the edges. The Innovation Center doesn't do that. The statute actually tells us, think of new things, and as long as they're either improving quality without increasing cost or decreasing cost without harming quality, they can be models, and they could become perpetual parts of the Medicare program. And so our job is actually to think of new things and be creative. And the type of person who's drawn to that is someone who's a go-getter. It's somebody who wants to work hard to drive change. And so I've been so impressed with everyone I've interacted with in the center. I had the privilege of knowing many of them before coming into this role as well from prior service. But it really is an exceptional team. And there's some great leaders here who want to understand where we're going and then think through, okay, based off that, here's how I drive it. Here are the operational steps, and we could do it. And we'll lay that out and align, and then we'll push forward. And so I think it does come down to some exceptional people in place, some new folks who have joined as well, that want to make a difference and care deeply about the patients and how they experience their interaction with their healthcare system.
So in addition to coming up with new innovative ideas and different things, have you been able to kind of reshape the board of how things actually get done at all? Like, how big have you gone with designing the Innovation Center as director? So
the priorities of what we do, there's been some shifts on, and it's all anchored in the statute. And so the statute is clear. These are the goals of the center. But what models we design, what approaches we use, how we get there is something where there's a broad latitude granted by Congress to the secretary and authority exercised by the center. And so, yeah, we're doing some things a bit differently. A lot builds on progress to date. There's 15 years of history. There are a lot of really good payment models. There's some things that we are in the process of tweaking. There are some things that we're continuing as is. And then there's some new things we're charging at. And those new things really were an agenda that we came in with as an administration, where we were pretty clear on what we want the healthcare system to look like a decade from now, and tried to think through, okay, if I want to get there, what do I need to do today? And how do these models change the system so that we're in a different place? So I don't want to go piecemeal, bit by bit, change how it's paid for this specialty or that specialty and do small things. I'd rather do things that, if certified, can reshape the healthcare system. It's not about the scale of the model being as big as possible. It's about testing something that if it works, and we know it works, we can then run nationwide. And that thing, if certified to run nationwide, should be something that changes the healthcare system to help people live healthier lives.
So it's kind of incredible that you're coming in at a time when I think that's uniquely almost possible, because there have been there have been these shifts and new technologies like Gen AI and all these things that are coming into play that are really, first of all, allowing for the rethink of some very fundamental processes, but also realizing adoption of these technologies. So it's not like you are sitting in the Innovation Center trying to hope that someone uses some kind of new tool, but it's something that's that the whole AI revolution has taken over in such a kind of seismic way. Has that impacted your ability to really redo a lot of these underlying concepts?
It's definitely part of it. If I think about new technologies and whether technology will be inflationary in the healthcare system or not, that's a government choice. What type of innovation we choose to incentivize is a choice as well. There's a concept used, the new technology add-on payment. We're like, oh, there's going to be a new technology. So to get the provider who has the relationship with the patient to use the technology, if we think it might be good, we should have an add-on payment to cover the cost of the technology so the provider doesn't lose money. And therefore, people would choose to use the new device. It's kind of a convoluted thing that to adopt new technology, we have to put extra incremental add-on payments in place. What I'd rather do is say, hey, if this makes your work more efficient, we should be willing to set up a structure where it's worth it for you to adopt it. Or if this is something that improves quality, we should have an add-on payment tied to the quality improvement, but not centrally plan, oh, this thing is better and that is not, and what things look like. I actually think the healthcare system really needs to have a structure where you know when you're developing technology what the reimbursement pathway could look like. And so you could think about that today as I could cut a deal with a big commercial payer and I know what they'll pay me for access to these things. That's why a lot of benefits of different technology or apps run through employers because it's through the commercial insurance. But if we want people to build solutions for the Medicaid patient or the Medicare patient, we need to have a pathway of what that reimbursement looks like that's predictable for the industry. And so thinking through what that looks like and how we enable new technology to come online in a way that becomes a useful tool to take cost out of the system, increase the supply, increase access, make it easier for people to get access to healthcare, that would be a good outcome. And so what that structure is something that we need to put thought into and develop to come to the market with.
Yeah. One of the concerns that I think a lot of physicians have when there's new models is that it's like, okay, here's this new opportunity, but now in order to do this, you have to document a certain way. You got to change your processes in addition to all the other things. So now you're part of ACO REACH and you're part of this, you're part of that. You're doing CCM, you're doing RPM, you're doing, whatever. And now we're going to try this new thing. And now you got to do things in addition to, and it just, each model seems to add this administrative burden that make it really, really difficult to be a part of and realize any kind of gains from it. I have my own thoughts on this, obviously, but how are you kind of thinking about that and planning on kind of addressing that?
Yeah. I think the shame is that it's not necessary. There's so much that actually could be aligned so you don't have to report the same thing 7 times. Why is it that in the quality payment program we run that we don't have alignment between that and the metrics used for stars? Why is it that when we will develop the quality metrics in our kidney care program, they didn't align with the stars quality metrics are? Sometimes there's a subtle difference. So we actually want to measure optimal starts in this way instead of dialysis. Okay, well, maybe we should revise it across the entire program. So one, what our measure is, and to the extent that could be standardized to create a clear incentive is something we need to think about. The other thing that I think we need to think about is whether we need the thing reported in multiple forms and times, or whether we could just say, hey, you know what? We'll get access to that information. Don't bother on your end with the paperwork. And you know what some of this technology enables is not just the private sector doing things with technology in a different way to care for patients. It's just simplifying the administrative burden because suddenly we'll on our end figure it out and draw those loops to satisfy the forms that the law requires without you needing to do something different. So your time could be spent sitting with somebody in the room and understanding their condition or helping them understand it so that they actually engage in the follow-up course of treatment.
Beautiful. Ladies and gentlemen, the conversation has now begun. This is exactly what I was talking about a little earlier, where with some other folks that you have this incredible, you have Gen AI, you have ML, you have all these different tools, and instead of making people, and the flip side to this is that with today's adoption of ambient, and I know this just zeroed into something very specific, but hey, that's the way it goes. I'm very ADD. I've given that disclaimer many
We'll just
times.
take everyone with us. Yeah,
yes.
Let's do it.
People are using ambient technology. They're using it to scribe their in-person stuff. Folks are using tools for care coordination. They're transcribing and analyzing and doing things for their conversations. And yet, for the vast majority, specifically when it comes to ambient in person, people are already listening to the conversations. They're already analyzing the conversations. And yet, the only thing that survives is this tiny little sliver at the top that's scraped off called documentation for the purposes of something. Maybe that something is for the for billing. So maybe it's a SOAP note, a progress note, or this note, or that note, a problem note, whatever. But if there was some way, and I think this is exactly what you start touching on, so I want to see if this is what you're saying, if there was a way to incentivize people to just give access to the actual underlying conversations. There's so much gold in these patient to doctor and patient to peer and patient to care coordinator conversations and interactions that is completely being lost. And then, just like you were saying, you can now just run analysis on it and be like, okay, now show me this, show me that, show me this, show me that. You can just look at everything.
We currently don't have access to your clinical record. And you can say, all right, we're the payer, we're not, but I mean, there's common standards, there's TEFCAs for how this should work. But even that is set up does the concept of a machine readable format even make sense today when we could just access all of this? It doesn't matter. So the standards we write should be modernized for like what the world is starting to look like now. And it's so easy to give access now. Yeah. And we should just enable that so that people could get care without burden.
Yeah. It'd be so powerful. I was talking to a gentleman named Eyal Zimlichman. He is the head of the Sheba Medical Center in Israel's Innovation Center, which is like it's like a countrywide. And granted, there are core differences between the United States and Israel. Specifically, they are essentially a socialist healthcare system, meaning the actual healthcare system is government owned and government operated. But they've had a nationwide EHR since 2004. And that has enabled them to collect all the data in one place and run on that data and invest in the data and come out with so much incredible, understanding. And so obviously there's massive differences here, but the idea of just like, hey, this has changed in the last 3 years, the ability to get access to an insane amount of just conversational data, interaction data, and actually do something intelligent with it is now a thing.
And we could actually have a federated system where this information is still distributed, but there's just common language and identifiers across. I mean, if you have a phone number and somebody's name and date of birth, like you could get that person. It's obviously there's some people without phone numbers, but like you're getting there for 90+% of people. So it's really possible to draw these connections and lines in a way that is different. And we need to be conscious of that when designing our models. And so, that shows up in a quality perspective. It shows up in the technology requirements we put in place. It shows up in how EHRs can support physicians who are in a different payment model and are spending their time differently.
Yeah. Okay, I have so much to go through, but I do want to talk about, so like I mentioned, you guys are moving very quickly and you put out your strategy letter and then shortly thereafter, you guys are going to start coming out with some pretty incredible actual models to put out. And so the first one is going to be this model that's actually dropping tomorrow called WISeR. What does that stand for?
So WISeR is the Wasteful and Inappropriate Services Reduction.
That was incredible.
It just rolls off the tongue. I prefer to just call it WISeR though.
Fair enough.
What WISeR is a model to help prevent people from being harmed by care that is really low value or harmful for them. If you think about things like arthroscopies, the type of tear that is common in the above 65 population is actually not something solvable by an arthroscopy. And an arthroscopy causes substantially more pain in the years afterwards if it is not appropriate for the tear. There's a reason why in professional athletes you don't do intensive surgeries. It's because you actually would rather do other forms of healing if you could avoid it, because you want them performing at their peak. What we do in WISeR is we look at care that might be harmful for patients, and we want to test if interventions to help guide people to other forms of care will be helpful at helping them access and improve quality care and resourcing and lowering federal spending on these services that are harmful to people or are subject to fraud. As another example, skin substitutes is an area where we've seen a surge in spend in the Medicare program.
Okay.
And so in WISeR, we'll be looking at testing if a process to review if this is a necessary procedure and guide someone to care that might be better for them will be helpful.
And this kind of really ties into part of that strategy letter that you talked about of empowering patients. And this sounds like it's definitely in that vein, right? Where you want to protect patients from being given treatments that are maybe ineffective or even harmful to them.
Yeah, things where there's not really a clinical evidence basis. Everything in this is something where we either have a national coverage determination or a local coverage determination that was put out saying, hey, this is where this is appropriate and this is where it's not. And what we're going to do is try and guide adherence to match that NCD or LCD. So it's really about looking at the clinical care guidelines and ensuring that those are adhered to.
Slightly off topic, but super related. Something that I've found really fascinating for a long time is, and specifically when you talk about something like this of empowering patients, and this speaks to patient empowerment in general, it would seem to me that the incentive structure for healthcare is almost that it's my doctor's problem that I should be either healthy or basically sick or healthy, fee for service or value-based care. My doctor is either the one that gets paid or gets dinged for my health.
Well, I mean, I think you also do, right? The copay that you'd have on this service, there's a 20% copay in Part B, would also hit you. And so it's your doctor's problem, but you're going to be charged for it also. It's not just the payer picking up the tab.
Right. But somehow, well, first of all, if you're Medicare, Medicaid, or if you have one of the many secondaries that will cover your copay, but even forget about who's picking up the copay, the general incentive structure and reimbursement goes to the physician, and that's the way it works. And the thing that I find interesting is that we live in a very instant gratification society, and therefore taking care of our health is not something that comes naturally to us wonderful Americans typically. And how do we get? Do you give any thought, or do you even think this is an issue? Basically, how do we get the patient to be equitably involved in the discussion of their own healthcare? Like when someone's actively sick, then unfortunately they're going to be involved, hopefully, because they're unfortunately in a bad situation. But when someone's healthy and young, you want them to be proactive about their health, the incentive structure is not there to the patients; it's there to the doctors. So when you talk about empowering people, it's amazing. But are people even looking for the empowerment?
I think there's two sides to it. One, they need a way to see it, and two, they need a reason to look.
Okay.
On the way to see it, and this ties in on multiple levels. Like they need access. You need a tool that gives you the information. You need price transparency so you could see the information, quality outcomes, quality transparency. The president has obviously given direction to the administration on these topics. But even if that exists, somebody might not engage with this information because it's time out of their day, something they might not have a reason to do. When I think about why the CalPERS study on knee replacements, why I showed it was effective, it's both that there was a reference price put in place of what they would pay, and people had access to information on what hospitals were charging. And so the hospitals that charge more, people would just choose not to go there and vote it with their feet. And that was effective because people knew CalPERS will pay this amount and not more. And then they had access to the pricing, so they'd go to the ones where they would not be paying out of pocket. And then all the hospitals dropped to the California reference price, of course. That's what you want to get to, with whether it's quality or cost. What you want to get to is a way where it's easy for someone to access that information.
Yeah.
And then it's easy for them, and they have a reason to access and act on it. And so if we set up an ecosystem where there are digital therapeutics or apps that people can access to help guide and manage their condition, we need to make it possible for somebody to bring the information to a patient, and then for the patient to easily engage with that and have a reason to engage. And that reason could be, hey, I care about it, I have a stake in this, I see the link to my health. I don't know if you've ever used a wearable, and you see this information, and then like the morning you get up after you had a drink the night before and you see, oh, your sleep score is worse. And then you feel guilty about it, and you're sharing it with your friends, so like you feel the public shaming because we respond to that as humans. That's effective, even if it's just with yourself, and suddenly you have a reason to care and engage. We need to encourage that with whether it's wearables or other types of devices or technologies. We need to make it easier for people to get information, and we need to give them a reason to care.
Yeah, so let's dig into giving them a reason to care. You've said it like a little bit on it, but that's the part that I really get stuck on. Like, how do we get and just to kind of maybe widen this piece of the conversation a little bit, when I speak to physicians, I've asked this question like dozens of times on the podcast at this point, and the question is, if you knew that you were caring for a patient for their entire life, and this was your patient, and you were fully at risk for this patient, what decade of the patient's life would you focus on for prevention? And the answer that I get pretty much 99% of the time is the patient's 40s. Because before 40s, pretty much you can come back from anything. After 50s, 60s, there's no such, you can't reverse. You can basically manage conditions. But if you end up with diabetes or whatever it is, hypertension or whatever it is, then that's where you're at. And now you're just managing it better or worse. But 40s is like, all right, let's get those habits in, diet, exercise, things like that. But in this country, it's kind of like pre-Medicare, post-Medicare. You basically have before 65 and after 65. And then in addition to that, and I know I'm going on a spiral here, but you're like the innovation guy. So I gotta hear your thoughts on this. In addition to that, patients get to choose who their payer is, right? And you can switch every single year. And so like the analogy that I give is like, imagine if you were buying a piece of real estate and you were expected to insure the real estate, but the real estate got to choose who owned it the next year, right? And so you'd be like, I'm not going to pay for a new roof and new plumbing and new, for this piece of real estate because it's not my choice whether I own it next year, right? So there's all of these things that make it really difficult to really drive forward value-based care. I know that was a ton, and I'm searching for the question within that haystack. But
well, let me pick out the question.
Sure.
Peter Attia in Outlive, he would suggest that earlier is better. Start in your 20s, start in your 30s. Don't even wait till your 40s. And start tracking in your health information and your lifestyle, because getting into habits comes hard to break them. And if something accumulates, it's harder to reverse. And building up muscle mass as you get older gets harder. Building that incremental, the amount of time working out you have to spend versus maintaining it, it matters, right? So the spiral after a fall, where if you have more muscle mass and so then you're week not working out or 2 weeks not working out, it's going to be hard to recover it when you're in your 60s, for example. I buy that. I think thinking through lifespan and thinking through health span matters, and doing the investments to extend that matters. Tools to engage people in that and help them be motivated to care about that and help enable them to care about that matters. In the Medicaid population, you actually have someone who suddenly has an incentive. People come in and out, but if they're coming in and out, they're coming back in. And so the state government and the MCO have a longer term incentive. There's also less choice there, varies by state. But even in the states that default, the rates of picking a different plan in Medicaid are quite low. And so you have someone that has responsibility for a younger population and can engage as a test to say, all right, let's actually think about health and think about engagement. It's a tough population you can engage. There are barriers, there's access barriers, but you can make an investment. And in the commercial population, there are some examples of long-term relationships where you have an incentive to engage. There's fewer with them each year, but think about unions and the employee base that is with the United Auto Workers and will be for decades, or public sector employees where you have a similar dynamic of public school teachers unions. Right. Suddenly you have an incentive to invest. And those with the employee group waiver, the EGWIP plans, you actually will have accountability on the post-65 population in Medicare, because a lot of those are structured through EGWIPs. And so there are pockets where that can be done, but there's not enough being done yet. And then as things are proven there, it becomes really doable, I think, to make the case to employer groups that as a benefit to attract people, you want to be doing these things as well. And so then you end up doing it for the commercial market. So there are areas where the government could drive the innovation, speaking, I guess, as the innovation guy. And there are areas then where the private sector can, if we put out information on how it's working and what's happening. And there are entities that could do this in the private sector as well and publish their own reports, and we can learn from that. It's a bi-directional pathway. And then come Medicare, where the government is the insurer for everyone. Obviously, there are other solutions that we could get to.
But there's always going to be core things about diet, exercise, and essentially medication adherence if you have anything, chronic, that are going to just remain, right? I mean, maybe it's vitamins and not medication. I don't know. But there's some pretty core things that we're always going to want to be doing, right?
And a lot of these supports are more about nudging you in that direction.
Yeah.
It's like the impulse control, the change in your eating behaviors is about nudging you onto this pathway and making it more doable for you.
Yeah.
So yeah, 100% agree. I mean, prevention activities and healthy living are at the heart of our strategy as a center now, because those changes pay massive dividends for health. I mean, I worked in the first Trump administration on trying to approve the application that Maine had submitted to not pay for soda in their SNAP program, food stamps, now called SNAP.
Yep.
In the end, the administration made a choice not to approve that waiver for other reasons, but I was a big supporter of supporting it, and the NEC advocated at the time for approving it because when Governor LePage submitted it, we saw massive dividends in reduced spend in the state Medicaid program and better health outcomes for the beneficiaries on Medicaid in Maine.
Yeah. And this is something I actually spoke with a Congressman, Jake Auchincloss on, and he had obviously, different takes on it. But that seems like a no-brainer. I mean, the idea that, that RFK has been talking about taking these kind of things off of being able to be purchased by government dollars essentially seems like a no-brainer. Where's that at? Where is that?
So there are many states now that have submitted applications. The secretary sort of got on a campaign to try and encourage that because it will make a difference. And then the USDA does the approval of those waivers. So it's not technically part of HHS.
Yeah. And there's like an argument like, oh, that's all they have access to in certain parts of the country is like gas stations and sodas and stuff like that. And it's like, I don't buy that. First of all, I grew up in Iowa, the middle of nowhere. Everyone has a Walmart. Everyone. And then second of all, if the gas stations or the corner shops would start carrying other things, if those are the things that can be paid for, like they get from the same distributors, they get soda, you get water, or whatever it is.
I think our role here in the government is structuring the market and structuring the apparatus. We're talking about government programs where the government is picking up the tab and paying for it. We have a duty to do it in a way that guides towards healthy decisions to help people live healthier lives. That's the mission of making America healthy again. And we shouldn't make the default that it's hard to be healthy.
Yeah.
And I think it's an imperative for us.
Okay, so then that leads into another question I have, which is, we want to make America healthy again, right? I would have to presume that like the strongest kind of, I don't know if it's lobbyists or like some of the strongest presence when it comes to like policy or people that are trying to get policy done is going to be the fast food industry and the insurances and the insurance industry. Wouldn't you think that those two, like if I was a payer, like which you are, right? Because the government is the payer. If you're the payer, wouldn't you want to be fighting tooth and nail against the fast food industry who literally employs, and this is not a conspiracy theory, I literally met some of these people who are food scientists that sit there all day and figuring out how to make that burger and French fries like the perfect amount of addictive so that you keep coming back. Like, wouldn't you think that those two would be in like complete opposition?
It's an interesting question. I mean, I meet with health plans all the time, regional blues from across the country, people from the national insurers, and most of them expressed interest in understanding the agenda and helping people live healthier lives. I think that's something that people are receptive to. They want to understand the rules of the road. They want to make sure we have visibility into the implications of our decisions. But, they're people in the industry responding to incentives, and our job is to help shape the incentives they operate under. And so I think they've sort of viewed food policy as probably out of the remit of what they could influence in Washington before now. Mm-hmm. But I don't think any of them oppose our efforts to help people live healthier lives.
No. All right. Requires further discussion. Let's move on. So we talked about the WISeR model, and you've got another one coming up very soon, which and I forget what it's called. Is it SMP?
ASM. Ambulatory Specialty Model. And so the name is meant to cover a couple of different specialties. The two in it are focused on lower back pain and a heart failure condition. Okay.
How'd you come up with lower back pain? And like heart, I get. That's like one of our biggest drivers of cost, right? Lower back pain. How'd you come up with that?
So when you think about things that are done in an ambulatory setting, so outside the hospital, there's a lot of things you could focus on. Oftentimes, pain is indicative of more underlying conditions and things that will emerge. Okay. So if you could get people to engage earlier on, there is a potential to help hold down the spend down the line, which is part of our statutory mission, and help people have manage their pain, help people work past it, and help people avoid more expensive procedures down the line. That makes sense to me. Prevention, earlier engagement to avoid something down the line that's not going to be as effective and has some risk.
Yep.
So lower back pain really fits in that bucket.
Huh. So you're saying the condition of having chronic lower back pain is indicative that a bunch of things are going to go wrong later.
Yeah.
What specific things?
I mean, if you think about it, like if you get this unmanaged, you might need a surgical intervention for it, right? If it becomes a chronic pain where it's hard for you to walk and hard for you to move, versus if you address it now, that is something that we could understand what behavior you're doing is influence this. Is it something about how you're walking? Is it lack of physical activity? Can you be doing more exercise? Is it a physical therapy solution? What is causing it? Getting at these things earlier on just makes sense.
So are you like trialing this model with something that falls in that bucket of like early prevention, and then something like heart disease, which is like kind of like falls in the bucket of like diabetes? Because like our two biggest things like hypertension, diabetes, right?
Yeah. I think there are some things in this where we're engaging early on. It's not a hospital focused like heart condition, which is what we typically have done in episodes. And so what was exciting to me about this structure is that we're getting earlier on here, even for something on the heart phase. It's just cardiology was a good area of focus. It's something that I think we'll probably come at from multiple angles. Within this structure, we're looking at working within the MIPS value framework, which is basically a way of influencing future year payments for the provider. So you have an incentive to engage now because your future year payments, if you are in if you're in the best performing group, will be higher. Mid performing group, stay normal. What it would be for someone else, and then the low performing group, there's a reduction. And so suddenly you're like, all right, I want to engage. I want to clear the quality metrics that are indicative of long-term outcomes in the performance year.
Got it. So you're going to borrow some like principles from MIPS, MIPS, right? Medicare incentive. I don't remember what it's for, but yeah, we deal with it all.
Yeah. Part of MACRA, big structure.
MIPS. So you're going to borrow some principles from there and then kind of zero in on a model that's targeted towards caring preventively for lower back pain and heart disease.
That's right.
Any details of like what that's going to mean, or that's kind of TBD of like what you're going to have to do?
So we'll be putting out to the public the structure of what will be in these, and then we'll accept comments in. So this is something that we're not just putting out and saying this is what it is. We're putting out and we're saying we want feedback. We want to get this right. Give us input on like, is this the right quality measure for OCA? Did we calculate this correctly? How should we think about who should be in it? And then we'll come out after getting that input with what the final version would be if we decide to move forward.
Yeah.
You see the government slow thing? Part of it is that stakeholders should have a say as they're being impacted by programs that are done on a mandatory basis like this one.
Yeah, I mean, look, at the end of the day, you want it to be effective, right? So you want to get all that feedback so that it could be effective. That is what you want. You don't want to just, project models at people and see what happens. So that's interesting. And you started telling me right before we hit recording, and I really want to hear about this. I asked you how you kind of come up with these models, and you said how you were in government and then you went home and then you literally have been thinking about things like this. I don't know if it's this in particular for like 4 years in your private life. You were thinking and thinking and thinking, and that's one of the reasons that you were able to kind of get this moving so quickly. Please tell me all about that.
Yeah, I mean, I refer to it as the off season, as in we were in Trump 1, and then I had the off season.
Yeah.
And what I did in that time is I literally was like, okay, I'm doing my life, I'm making investments. But as I'd see things, I'm like, well, that's wrong. It shouldn't work this way. This is a really poor incentive structure set up that's harming patients. One, I would tell friends and my friends from across the aisle in government, like, hey, you guys should fix this. I'd occasionally talk about things with other policymakers. I wrote an article or two, but I also would just jot it down. And so I started building out a list of hey, here are things that could be done differently in health policy and payments. And I'd speak with them with friends and just try and get, feedback to refine them. And so I had a running like Word document where I had here are ideas of things that the Innovation Center could do differently.
Wow.
That was just,
You had no idea that you would end up you had no idea at that point if Trump would run again. You had no idea that you would end up here. And yet you were just kind of like thinking.
Just thinking for the future because of ideas that I thought should be done differently here. And I think this is really one of the most critical parts of CMS and of the healthcare system, with the opportunity to make a difference in what things look like. And so building up that list was important to me because I just thought it was important to have something ready. I didn't know I'd be here. That is something that is, luck, by the grace of God, whatever you want to call it, but it's something that right place, right time happened, and it's a privilege to be here and get to work with this incredible team day in and day out. But I intended to bring those ideas to whoever had the seat and tell them, hey, these are things that you should do because they make a difference for people and they matter and we should work through them. And so I came in with a list of ideas, and then I literally sent an email in the afternoon on January 20th to my team, like, hi, nice to meet you all. Let's meet at 9 a.m. tomorrow morning. And so on January 21st, walked into the room and I handed out copies and I'm like, all right, let's go and discuss this. What other ideas do you have? Let's spend some time over the next few weeks working through this and get to an idea that we could bring together to the center and the group directors and get buy-in and build consensus on, and then move forward on. And so we, by mid-February, had an idea of here are the models that we want to put out this year, where we then proceeded to start working and brief up in the administration to be able to put out models quickly.
So, first of all, by the way, it feels like the whole administration feels the way you did, where they had like an off season. It feels like everyone came in with like ready to go, which is like a really cool vibe. But yeah, in particular. So how do you think that 4 years is enough for you to get the things that you want to get done? Because there's some things which I think are really, really important to even talk about. There's a lot of continuity. Like, it's not like, the government, DC, obviously can be extremely polarizing, right? You've got two sides of the country and whatever, but HHS and healthcare should not be political. Healthcare should be, we all just want to live healthy lives. We want healthcare to be cheaper. We want it to be better. We all want the same things when it comes to healthcare. And so I think it's really important that there's a lot of continuity, and it seems like there is throughout different things, even like you talking about borrowing principles from MIPS and then just adjusting it here and like kind of making tweaks and efficiencies and, but there are some things, and I think once again, you're kind of, it's really interesting that you are sitting at this point in history where this kind of technological revolution is happening at the same time, where you can really empower, HHS revolution as well. Do you think that 4 years is enough time? And are you concerned that you won't get enough done to where whatever happens after 4 years, it'll just like be a non-starter? Like, how do you think about this clock that you're on?
I agree that there's broad continuity. There's path dependency in anything, right? In technical systems that exist operationally inform what we do. I'm learning from lessons of what's happened in the past 15 years at the center. Republican, Democrat, doesn't matter. There are things that because of what results and what was certifiable or not, I'm doing things a certain way. And that's information that when Adam Bowler was in this office, he didn't have, and when Liz Fowler was in this office, she didn't have either. And so all the prior directors reacted to the information and the environment they were in. I have the benefit of more history and more information, which is helpful and an advantage. I know that there are things I want to move, and I hope we get as much of it done as possible. I also know that it's helpful for me to have been on the other side of things, participating in models and learning what that experience is, because it's helped me identify things that I want to move on and that I think are important for the healthcare system in support of Secretary Kennedy and Dr. Oz's agenda, in support of the president's broad vision. I think it's helpful to have rotations in these positions and have people come in with that private sector perspective, who have a deep understanding of how the structure works, so that they could bring a new set of eyes and refresh that as well. And so I don't think you'd want me sitting in the seat for the next 40 years running the Innovation Center. I think you want some turnover there just to bring fresh perspective.
Right. But do you think 4 years is enough time to get done what you want to get done?
I think we can move a lot forward, and this team is working really hard. We'll see, right? Yeah. We're going to move as much as we can, and my hope is that we move things that people recognize are the right thing for the country, and that we continue to be moved. Our experiments that we launched today will not really be done by 4 years from now.
Yeah.
Right, and that's the nature of it. It takes time to design an experiment. We're moving fast, but then the experiment launches, let's say, next year or the year after, depending on which one,
Right.
in the structure. And then it needs time to run, and we need time to get that data. And so with the things that I look to certify over this time, if there are any that meet that standard, will be things designed by prior directors. And so that is the nature of stepping into a center and running it, and then being ready to hand it off to whoever the successor is at the right time.
Yeah. Totally ADD. Who hires you? The secretary or doctor or the administrator?
So the process for being an appointee in the government is, in this case, Dr. Oz hired his team, and so he said he thought I would be good for the role. And then the secretary's team.
Did you have any interaction with him?
I had not met him before my interview. Walked in and spoke about the center.
He found a Google Doc lying around with a bunch of incredible ideas.
Yeah.
He's like, who wrote this?
Someone from the Kennedy campaign had reached out to me. I had worked on the healthcare transition team for the Trump transition, but a mutual friend introduced me to someone from the Kennedy campaign who was looking for people for different roles, including this one, and they got my resume in front of Dr. Oz. I had a mutual friend with one of his sons-in-law as well, and so the resume came from multiple sources, and he invited me down to meet, we met on a Friday afternoon, and then he asked me to come back again on Monday, and he offered me the job that Monday.
Wow.
It took a bit of time as the team was building out for the formal approval to come through, because in the process, the secretary's team buys in on roles, and then the president's team does their review as well. And so it was formalized in early January, and then there was a whole process of ethics and preparing stuff to come in to be clear to start on the 20th. I think my final like ethics, everything checked, happened on the 19th. So
February
of January.
January.
Start on January 20th.
Right, because you said, and then the next day you already had your meeting.
Yeah, I think it was like something like that.
Wow. Was it like a hard decision for you to like leave? Like, how was that feeling? Like when you got that email, like, hey, you're the guy.
I mean, I'd been working on an idea that was going to be my third company launch from Rubicon. And the first one that really I thought of the idea, and I ran out and signed all the partners, and I built up the model, and it was really me driving totally on my own. Mm-hmm. The others I'd really worked with co-founders on. And so I was really into this. I spent all of 2024 on it, and I signed my term sheet with the anchor partner for it the week of the election.
Oh my goodness.
And I stepped away from it because the opportunity to serve here was not something I could turn away from. Yeah. And I have no idea what's happened with it.
Wow. And you can't ask, and you can't.
The ethics rules are really strict here, and we were really careful in abiding by
100%. That's a sacrifice. That's really cool.
I mean, it's fun. That's the thing that I think people, like, when you think about government and what's involved, people don't get. There's like the ability to learn about all these different things. There's ability to think through different structures. And there's just great people coming in to speak with you, and also like in the team here who are just driven to make a difference, and getting to spend all day thinking through how should this be structured? How can we make it better? It's just, there's a thrill to it. It's exciting. It's a privilege.
I think it's phenomenal because, and I said this a little earlier, but speaking with you and speaking with all the people on your team, it's not just, it's high energy. Like, you guys have this high energy, which I think is pretty, I don't know about, I think it's probably difficult to have that working in the confines of government. So it's cool to, I mean, is there small ways?
We were all drawn to this. I mean, I think it's the opportunity to serve and be here that really keeps a difference, in knowing that our work can make things better. I mean, the team here is all here because they want to be here. Everyone here, could be, I assure you, they could be earning more in the private sector. They're here because of the ability to make a difference. It's a great feeling.
Yeah, it's really credible.
It's harder at 1 a.m. to say this, but we're recording in the afternoon, so I'm still fine.
Right, this is the morning for you because you go all the way till 1 a.m. Really incredible. Abe, I've heard so much about you from you speaking on, different panels, and everyone that's come across you has said, from any different side of the political spectrum has said, Abe's a great guy and he's in the right place and he's doing good things. And so it's really, really amazing to sit here and kind of talk about it and, communicate this out. Excited to hear about both of those models, the WISeR model and, don't tell me, ASM.
Yeah, you got it.
Oh, the ASM model.
This was a test, and you passed. So
Right. Yeah, there's no fun acronym for it, so it's a little different.
Yeah, it's hard.
gotta talk to the
I
rest of
am
the
more
basement.
drawn to the fun acronyms. I'll admit, like we pick something that communicates like the heart or the message of it,
Right.
and then we have it. But I think there is something also in an understandable framework where someone looking at it could get, oh, this is about ambulatory areas.
Yeah, like it makes a lot of sense. So really excited to see those come out, and we'll be able to announce this and see how they get worked on. So yeah, really awesome, man.
Thank you so much for the invitation to be on. It's great to speak with you and your listeners.
Pleasure.
Thanks, Mendel.